Hi, my name is Norma Johnson. I am, I want to, yep, it looks like I am recording. I am a licensed pharmacist as well as a licensed insurance agent. Let me share my screen so you can actually see me. I wanted to make this presentation because I spend the vast majority of my time talking about Medicare Part D. And at no time since the inception of Medicare Part D in 2026 is the conversation around Medicare Part D so important, because the Inflation Reduction Act is greatly changing how Medicare Part D is structured. And that causes certain challenges. It causes positives and it causes negatives. So it's one of those things that we all talk about Medicare, but we don't focus enough on Medicare Part D. A little bit about me. Again, my name is Norma Johnson. I am a licensed pharmacist. I have been in the pharmaceutical industry for approximately 25 years. I worked for a large retailer for 22 of those years. And I really have a passion for helping people, all people, find savings on prescription meds, because I was in the pharmacy prior to Medicare Part D. So of course, people on Medicare didn't have drug coverage. So if they couldn't afford the medication, unfortunately, those that couldn't afford the medication went without. And that just was a travesty. So myself and my team would go and we would search out whether patient assistance or grants. Not long after that, discount cards came out. When could somebody use a discount card? What if somebody had employer coverage, but the employer coverage still had a high copay? Was there a manufacturing discount card that could be used along with the insurance to help? There's so many different strategies that people can use that they're not even aware of to afford medication. And that's both inside your prescription drug plan as well as outside your prescription drug plan. And that's been my passion for 25 years. And of course, I've become very good at it. And as such, I train the vast majority of insurance agents in the country about Medicare Part D, and I have a platform that is used, excuse me, to train agents across the country in Medicare Part D and strategies for to find savings on prescription drugs. Because sometimes people have employer coverage. Sometimes people have ACA marketplace insurance. Sometimes family members of some of the clients don't have insurance at all, and they need some help and some guidance on how to get prescription meds. And that's where I spend the vast majority of my time. Excuse me, Tennessee allergies. And this is all live. So I am going to share my screen because what I would like to do, and of course I am recording this and I hope everybody can see this, is that I want to discuss Medicare Part D in a deep dive. So I've titled this Deep Dive into Medicare Part D, Past, Present, and Future, because all people need to understand where it started, how it is, how it was created, the foundational principles, and what has been happening, and where are we at now? Because there's big changes coming because of the Inflation Reduction Act. It has been a trickle effect since 2023, but the big changes are happening and people are getting what we call ANOC in the insurance world. It's their annual notice of change. People are going to be upset, confused. Plans are being discontinued and they're going to be losing coverage if they don't take action. And it's important that we get this message out there. So I'm going to post this on YouTube under my channel. But if you know anybody that would benefit from watching this video, please send them there. I need this across the country. Every Medicare recipient that has an opportunity to watch this video needs to watch this video. It doesn't matter if you have an agent in whatever state that you're in. If you go to your pharmacy and your retail pharmacy helps you print out a comparison, and then you call a carrier to enroll. Maybe you are comfortable with the computer and you use Medicare.gov. Maybe you call one of the SHIPs or the state health insurance places and they help you. However you get help to enroll, this is the year you must do something. Medicare has said that in the typical year, about 11% of the entire population that is Medicare recipients review and change plans, 11%. This year, it is anticipated from their estimates that over 80% of all Medicare recipients are going to need to review and make a change this year. There's not enough insurance agents in the country to cover that kind of demand. We're going to have some challenges. There's going to be long hold times for carriers. I hope Medicare.gov holds up. There'll be long lines to talk to SHIP. But whatever you do, start early. AEP, annual enrollment period, starts October 15th. And it goes to December 7th, and that ends at midnight at December 7th. You must do something this year, so it's important. So let's get into this because I can get a little gabby. So I'm definitely passionate about this. And protecting our Medicare recipients is very near and dear to my heart. So the past, so life before Medicare Part D, and I've already touched on this, is that prior to 2006, people that were Medicare recipients didn't have prescription drug coverage. That didn't come, in long until 2006. So if you were prescribed a medication, it was out of pocket, and if you couldn't afford whatever the price was, unfortunately, you either had to rely on samples from the doctor's office if they got any, or you went without. The thing back then, being in the pharmacy, that I recognize is the fact that back then, it seemed like there were a lot more generic medications than there are today. Today, we have a lot of brand name medications, and those brand names come with some significantly large price tags. So when we're dealing with brands, we're dealing with higher costing meds. The generics are always more inexpensive. Doesn't mean that they're all inexpensive. They're just less expensive than the brands. So before Medicare Part D, that's what we had. And of course, some of you that might be watching this video lived through it, so you understand and know where we were. So the government did made a huge step in the right direction when they introduced Medicare Part D, and it was introduced in 2003 as part of the Medicare Modernization Act. So it was really the first significant milestone that the government had done in order to bring prescription drug coverage. And the whole premise of it was a program designed and managed, operated by Medicare, but it is facilitated in cooperation with private insurance companies. So there is, and it's also subsidized by Medicare with these private insurance companies. So believe it or not, something as large as Medicare Part D is built on 5 foundational principles. To me, that's fascinating. So choice and competition. It's a choice between plans and the competition between these plans. And we'll talk more about that in just a little bit, because there has been a consolidation of the market that has put significant strain on this one foundational principle. Universal accessibility. Now that's still alive and well. So all Medicare beneficiaries, regardless of income, health, where you live, as long as you are eligible for Medicare, you are eligible to enroll into a Medicare Part D plan. That is still intact. I'm going to skip down one and talk about protection for low-income beneficiaries. We call them dual eligibles. Those are people that are eligible for Medicare and Medicaid. And then there's the extra help for those incomes a little bit higher than what they would be for somebody that qualifies for Medicaid, but still not very high. So they get extra help. That is also intact. Innovation and efficiency was just thought of, the whole idea was by utilizing what's called pharmacy benefit managers. We also call them PBMs, pharmacy benefit managers, by utilizing them to manage the Part D program. Now, who are they? And we'll definitely talk about more of this, but they are pharmacy benefit managers, just like their name says. They were around before Part D started. They manage prescriptions, so they have contracts with the manufacturers. They go in and negotiate drug prices. They're very good at it. They're part of the exchange of claims between the pharmacy and the plan in order to have it adjudicated so that everybody gets paid. By utilizing that group, they had the experience, they had the contracts, they had the connections. By incorporating them into Part D, by partnering them with the carriers, then we would have the carriers who were very good at doing healthcare, but weren't very good at doing prescriptions. So by utilizing the pharmacy benefit managers, then now we have the healthcare expertise and the prescription drug expertise. And that's the way it was supposed to go. And that's the way it has been going, but there's challenges. Shared responsibility right here. This is huge because one of these 5 foundational principles is the shared responsibility among the federal government, so taxpayer money, the Medicare beneficiary themselves in the form of premiums and copays, and private plan providers. So the plans, right? They were all sharing the cost. And this cost share is what's getting shifted with the Inflation Reduction Act. So honestly, 3 of these 5 principles are being jeopardized. And it does concern me as somebody that's been in this for a long time, that if we're not very careful, if government is not very careful, they will crumble Part D. And then what do we have? We get to start back over. So there are some major concerns, but for right now, everything is okay. We're going to go through some challenges. And then hopefully in 2025, maybe we'll get some adjustments. We'll see. And maybe we can get a little bit more stability, which we're going to need. So choice and competition has become an issue because you have pharmacies who have bought pharmacy benefit managers. You have pharmacy benefit managers that have bought insurance carriers. You've had insurance carriers buy up pharmacy benefit managers, buy up pharmacies, buy up doctor groups, buy up specialty pharmacies. You see the problem. And if a lot of you, if you're older, maybe you remember Mama Bell, right? The phone companies consolidated too much, and then we ended up having runaway prices. I was little back then, but it was, I just remember the Baby Bells, right? So it's kind of the same thing, in my opinion. We have too much consolidation, and if you have too much consolidation, you no longer have competition, and that's not a good thing. When this started, we had individual insurance carriers, and then we had individual pharmacy benefit managers. So every 2 to 3 years, the carriers would have to negotiate with the pharmacy benefit managers. They would wheel and deal, put in their bids, and they would determine which pharmacy benefit manager they were going to align with for that length of that contract. That's proper choice and competition, because then if they didn't like that, their deal, in 2 to 3 years, depending on the length of their contract, they could get out of it and go switch to another pharmacy benefit manager. Well, now, if you have a health plan that's owned by the pharmacy benefit manager, you don't have an option. Or maybe the health plan is the one that bought the pharmacy benefit manager. Now you have an investment. You're not going to go use a competitor of one of your own companies. This is a problem. We have straight vertical lines. And so we have United Healthcare owns OptumRx. So you have a health plan owning a pharmacy benefit manager. United Healthcare is also one of the largest purchasers of our doctor organizations. So they own a lot of doctor practices. They also have specialty pharmacies. CVS Pharmacy back in the day bought Caremark. So a pharmacy bought a pharmacy benefit manager. They become CVS Health. What have they done? They've bought Aetna. So now you have a pharmacy benefit manager and pharmacy buying an health plan. You have Cigna. Cigna owns Express Scripts. Caremark, OptumRx, and Express Scripts, the largest 3 pharmacy benefit managers in our country. It is reported that they control over 80% of all medications in our country, the movement, the sale, everything they control. That is a lot of power, and that can cause problems. So vertical consolidation is a huge problem. Now, there are a few positive things, potentially. I mean, potentially, we have to look at the good and the bad. So consolidation can mean increased cost savings, because now the bigger can buy more, right? Buy less, right? The bigger you are, the more you can command a lower price. That would be a good thing. Improved care coordination. So now you have different entities communicating back and forth. That's good. Especially being from the pharmacy world, we're kind of blind to a lot of things. And we need to understand what all medications people are taking so that we could catch drug interactions and issues and duplications. So communication is good. And enhanced negotiation power, that kind of goes along with the bigger you are, the more you can command more savings. So those would be good things. However, where there's good, there's bad, right? Because reduced competition also causes greed, right? Unfortunately, it requires us to have a lot of faith in those companies when they control that much power. And we're not talking about our food source. We're talking about medications, medication for cancer, medication for life-threatening conditions. Now, food is important as well, don't get me wrong. And we have to be careful there. But consolidation can be a huge problem. Also, a conflict of interest. When you get consolidation like that, it limits choice. And limiting choice is not always good. And sometimes conflicts of interest can be introduced, and that's a lot of what's happening. And of course, we can get like regulatory scrutiny. We need more. I'm here to tell you, we need more scrutiny because something needs to be done. Congress has figured this out, and that's what they're actively doing with the Inflation Reduction Act. I just don't feel like they completely understood the dynamics of the pharmaceutical industry before they quickly came up with this bill. So this chart is not mine. It's a beautiful chart. It's Drug Channel Institute. And I hope they forgive me for showing it, but it does show, and I'll just quickly show it, but it does show the consolidation. So all those vertical lines are all involved. So that's not a good thing. Pharmacy benefit managers, that's what we've been talking about. They were supposed to be the ones that partnered with the health plans so that they could go and help us drive down the cost of medication, go and wheel and deal with the manufacturers, get discounts, bring those discounts back to the health plan, to the consumer, to Medicare. That's not what has happened. Unfortunately, yes, they've gone in, they've negotiated prices in the form of rebates. Where'd the rebates go? Well, unfortunately, the rebates have gone in their pocket, in their bank account. They didn't get moved down. They haven't gotten shared. That's the problem. So we always want to talk about big pharma, big pharma. I'm not here to say we don't have some issues with drug costs, But I also can look at that on both sides and say, you know what, we also have a lot of government red tape, a lot of regulations because of environment or control. Certain institutes have to have some relevance, so that means they need to have some power in order to exert their demands and requests. So it causes red tape, and red tape costs money, right? So the pharmacy benefit managers, they have a lot to do with research and development, trying to come out with new drugs, better drugs, drugs to cure different types of illnesses, different types of cancers. And our pharmaceutical companies have done a fantastic job coming up with new medications for different disease states. They have really have. Does it warrant the large prices? It might up at the front end because it costs a lot of money to get their money back that they've had to invest. You know, does the United States pay more money than any other country? Yes, that is true. Yes, we actually do. Why is that? Well, we also want to be first in line. And unfortunately, if you want the Mercedes, it's going to cost you the price of a Mercedes. If you're willing to wait in the end of the line, and perhaps you're going to get a Toyota or a Ford or something that doesn't cost as much as a Mercedes, then maybe you're going to pay less of price. But if you want the nice, beautiful, fancy Mercedes, you're unfortunately going to have to pay a steeper price. And that is what we've been doing. But we also have had the benefit of being the first to line. And sometimes if you have a family member who is dying of a particular illness, a particular cancer, and all of a sudden one of our manufacturing companies find a medication that would significantly prolong that person's life if they had access to that medication. And if we weren't first in line and we had to wait until other countries got it first, that would be heartbreaking. But that's actually where we're heading because of drug negotiations. But that's another topic for another day. But you know, so big pharma, yes, there's issues. Yes, we need some reforms, but we must rein in the pharmacy benefit managers. We must demand that they share in some of the rebate that they are getting. There has to be far more, there has to be some transparency. Right now, there is no transparency. And so we don't know how much rebate they're getting. They don't tell us. They're not required to tell us. And therefore, we're actually looking at it kind of blind. Things need to change. And that is what the Congress is doing. But like I said, depends on where the control is, right? So we're going to talk about more of that in just a moment. But what does this all cause? Because of the pharmacy benefit manager control, well, we have a consolidation of market. We have a vertical integration, right? That line. We have less competition because you think of all the people that we have, we don't have that many carriers. We need more carriers, not less carriers. We need more plan options, not less plan options. And we need more transparency. So of course, with the pharmacy benefit managers, we have less transparency. We need complete transparency. It doesn't mean that we cannot get on board to the fact that they must make money. They're doing an important job. I understand they must make money, but in no way, shape, or form should they be doing what they are doing. So as a result, instead of drug prices lowering, we are getting higher drug prices. Consumers have fewer choices instead of more choices. We're even with our in-network pharmacy options, those are shrinking. And if you're out of plan, you know what I'm talking about. You're told which pharmacy you can go to. Would you like to go to an independent pharmacy, which is a mom and pop? Are the bases of our country, our small businesses? Unfortunately, with the vast majority of pharmacy or of Part D plans, no, you can't go to an independent pharmacy. And then we want to know what's happening and why is our independent pharmacies collapsing and going broke? Pharmacy benefit managers, another topic we'll talk about in another day. But networks in pharmacies are shrinking, and medication management. So you have prior authorizations, you have step therapies, you have quantity limits. Those are all medication utilization review processes that plans will put in place. I call them also hurdles because, of course, it slows up the process. I have a patient that needs a medication and they need to start on it today. If it needs a prior authorization, there's a very good chance they're not getting it today because the doctor's office has to do more paperwork versus just the doctor saying, hey, this person needs this medication today. No, insurance wants more paperwork, more red tape to say, okay, this is why they need it. And okay, yeah, we'll pay for it if we have to, right? No, we need less than that. We need better operations than that. So presently, we have the Inflation Reduction Act. And we'll talk more about that in a minute. But I think it's absolutely telling when we can look at the different bills currently in our government offices. You have HR 5376, and it's titled Share the Savings with Seniors Act. You have HR 6283, Delinking Revenue from Unfair Gouging Act. And then HR 2880, Protecting Patients Against PBM Abuses Act. I think that the titles are eye-opening, but they're also disheartening. In the United States, why do we have to have bills like this, right? Why do companies have to have so much power that they could put us in a position that we need to have all these bills to demand fairness, to demand that they do what their job was supposed to do? You know, was there a mistake at the beginning? Yes, yes, yes. I think if Congress would have realized the greed that would take place at the pharmacy benefit managers, maybe they would have built in some laws to protect us from that. But unfortunately, things sometimes get rushed through, and sometimes we don't know enough information. Hindsight's always 2020. And in this case, it's clear now what's going on, but now we have to fix it. So the Inflation Reduction Act, of course, is a landmark piece of legislation. It was passed. President Biden signed it August 16th, 2022. And it's not just about healthcare. It has other things included in that. But what is affecting the Medicare space is the healthcare policy changes. So it's aimed at lowering the cost of drugs for Americans. That's the whole premise. So Congress, of course, a few years back, just to take a step back, a few years back, and I don't know for sure if this is exactly where it started, but I remember it in Ohio because I've practiced pharmacy in Ohio for a lot of years. I went to the Ohio State College of Pharmacy. Woo woo, go Bucks. But pharmacists in Ohio can have loud voices. And several of them got very loud and brought out some corruption that was involved, some cover-ups that were involved, and it kind of exposed the pharmacy benefit managers and some practices dealing not with Medicare per se, but with Medicaid. And so it really put a spotlight on the pharmacy benefit managers. And since then, they haven't gotten out of the spotlight, right? They try to hide. You don't see them anywhere. I go to a lot of conferences, never seen one of them, Never seen one of them. Never will we see one of them. They stay hidden. They like it that way because apparently they don't like coming out. So we never see them. So the spotlight's been put on them, and Congress has gotten ticked off. They've realized it's like, wait a second, these people have way too much power. They're not giving us, they're not sharing in the rebates that we thought they were going to share with us and with consumers. We have to fix this. So of course, they took a bat to the anthill. I mean, being the fact that I am from the South, even though I did go to Ohio State and I lived in Ohio, I'm still from the South. And we have anthills down there. And if any of you can relate, so if you disrupt one of those anthills, the anthill is built with mud and things, and it's very hard. You go up and poke it a little bit. It's not sand, right? It's like encased. So it's sturdy, right? Kind of like a pharmacy benefit manager, kind of like a bad policy. It's stuck. Well, you go and take a bat to it, what happens? Well, if you know anything about fire ants, they come out in the billions. I say billions, I don't know, I'm making that up. It could be millions, but it's a bunch of very, very mad fire ants come out. And they do not care who swung the bat, right? Government swung the bat. They don't care that government swung the bat. They're going to sting the government. They're going to sting the plans. They're going to sting the consumers. They're going to sting anything and everybody around them because all they're doing is protecting themselves. And that's kind of like how I describe Congress in taking the bat to the pharmacy benefit managers and to Part D in general and say, look, this isn't going to work, guys. We're going to have to bring into some control. But who are they moving the cost to? So let's get into this. So let's talk before we get our blood pressure, because I can get my blood pressure up. Let's talk about the positives, because there has been some positives of the Inflation Reduction Act. There are positives of the Inflation Reduction Act. The problem is where it's aimed at is kind of off target. We'll see that in a minute. So the first thing that happened in January of 2023 is the Insulin Savings Program. Very good program. Insulin, absolutely necessary for somebody dependent on insulin. They will die without it. It was god-awful expensive for years, and it was all brand name. That's where the manufacturers could take some ownership. We understand patent laws, and you are entitled to so many years of protection. But at some point, enough is enough. And especially when it comes to certain medications that are life-threatening medications, as soon as that patent is over, we need the generics. We do not need games. We do not need extensions. We don't need games, guys. Let's just give us the generic as quickly as we can get it. We've paid our dues as citizens, and we've paid your high prices. You should have made your money back. Otherwise, maybe you didn't price it in the market right to begin with. But it's time for our generics. Anyway, so the Insulin Savings Program caps insulin at $35 per month copay, but the insulin must be on the formulary. And some of my pharmacy colleagues don't understand this program because, of course, consumers don't understand it. So you get a patient that comes in all mad because they can't get their GLP-1, their Ozempic, their Trulicity, their Mounjaro, their Wegovy, their Zepbound. Okay, I have type 2 diabetes. I'm using this for type 2 diabetes. Why is it not part of the insulin savings program? It's not insulin. The insulin savings program is only for insulin, not the GLP-1s. Those are not going to be included. And that hopefully can clear up some of the confusion. The insulins must be on formulary. So if you have a patient who is on one particular carrier and they're on say Humalog, and Humalog is not on that carrier's formulary, it's not going to be part of the insulin savings program. They're either going to have to change insulins or change plans. And depending on the time of the year, it's easier to change insulins so you can get it on the insulin savings program than it is to change plans, because there's limitations on when you can change plans. In 2024, what happened? Well, let me take a step back, because we also got the more vaccines. So we had the insulins and we have the expanded vaccines. So we actually ended up getting coverage on Part D, right? Medicare Part D for the Shingrix shot and RSV shot and other vaccines that are deemed really very important for us to be able to have access to. So the expanded vaccines definitely helped a lot of people save money and gave them access to vaccines that, help us eradicate certain diseases. Some vaccines go under Part B, like boy, right? They go under Part B and they're billed under the health plan, the flu, COVID, those types, the pneumonia, those types of things. The Shingrix, RSV, and some others go under Part D. There's a difference. Make sure you know the difference. So that both happened in 2023. In 2024, the big thing that happened was when people hit catastrophic, and that's we're currently in 2024. So when somebody gets to catastrophic, which for Medicare Part D right now, it's $8,000. That's not $8,000 out of somebody's pocket. They're paying approximately $3,200 of it. The manufacturer has a part of that that they're contributing that also gets counted to the what we call true out of pocket. That is what ends up getting them to the catastrophic level. But when somebody hits catastrophic and it goes over $8,000, then they no longer are paying 5% because they've been paying 5%. I'll show you another chart here in a moment. No longer are they paying. So now if they hit catastrophic, all on formulary medications are zero. Now, if they're not on formulary, it's no game. On formulary, there must be on formulary medications would be then zero because they have reached catastrophic. That 5% gets pushed off to the plans. Then, of course, we have the starting of 2025. We have a couple of things. One, Medicare can now negotiate some high cost drugs. They just did that. They had the first 10 out of thousands of drugs is not going to do us much good. And as much as excitement as that is being talked about, that doesn't even go into effect until 2026. So we still have a long way to wait. Yeah, they might have negotiated, but we don't even get those prices until 2026. So it's not going to have much of a difference right now. The big thing that's happening is the max out of pocket for Part D drugs for the first time ever. Before there hasn't been a max. So we've had the stages, right? You go through the deductible, you go into the initial coverage phase, you go into the gap or the donut hole, and then you go into catastrophic. Now, kind of in 2024, the top of the catastrophic, we could look at that as a max out of pocket, because once you've paid all of that in, then you're done paying for your drugs. But it was expensive. So in 2025, we have a max out of pocket starting of $2,000. Now, will that help everybody? No, it'll help some people that are taking expensive medications. It's definitely going to help them because they won't be paying out the approximately $3,200 that they've been paying out right here. It's now going to be capped at $2,000. The problem is that not everybody takes expensive medications. So the people that are taking the low-cost generics who still need a prescription drug plan, because if they try to go without one, they will be penalized by Medicare for not having a prescription drug plan. So therefore, they need to have a prescription drug plan. But unfortunately, they're going to be picking up part of the bill for the people that are taking the expensive meds. That's just the way it is. So some people will benefit. Other people, unfortunately, are not going to benefit. Again, this slide is not mine. I hope KFF does not mind me showing it just briefly, but they did a fantastic job of of showcasing what these amounts look like. So, and I've already talked about this in detail, that we used to have to pay 5% in 2023 when you hit catastrophic. That is now gone. But what you see here is a complete shift. So in 2023, 2024, they're identical, except for this 5%. This 5% was swallowed right here by the plan, which meant now the carrier of the plan had to pick up that. The big thing that's changing is this 80% right up here. Because since the inception of Part D, Medicare has been picking up 80% of the tab for all medications in the catastrophic level. So these hundreds of thousands of dollars of medications for people that are battling cancer or other major illnesses, autoimmune conditions, and so forth. Very expensive medications. Medicare has been picking up 80% of the tab because of the Inflation Reduction Act. Remember that cost share we talked about at the beginning. That cost share is now shifting in a very, very big way. And what it's doing is Medicare is saying, okay, we're no longer paying 80% of the tab. We're going to be paying 20% of the tab. And you, the carrier, gets to pick up 60% of the tab. So there's been a little bit of an adjustment. Let me explain this. So the deductible phase, this is still the consumer, the Medicare recipient. If there is a deductible, that's all on you. Then you go into the initial coverage phase. So the consumer would be paying up to 25%. That's the same thing as here, which is all the way back to 2026. So the consumer pays 25%. The plan has been paying 75% in the initial coverage phase. That's actually going down for some drugs, not all. Some drugs, they'll be paying 65%. So they get a little bit of a decrease. And the manufacturer is coming into this phase because the donut hole, which is right here, this big green, is now gone in 2025. It's not here. The gap is gone. Whoops, let me go back to that. So the manufacturer is coming forward into the initial coverage phase. Now, not all drugs are they going to be contributing 10%. On some they will. So on the ones they will, fine, the plan can pay 65%. They get a little bit of a cost savings and the manufacturer will pay 10%. But once somebody hits $2,000 max out of pocket, the person, the Medicare recipient, is done paying for their medications. So that is where the relief is going to come from. So max out of pocket being $2,000. But what happens is because the plan is now, instead of paying 20%, they're paying 60%. They're having to absorb the extra cost. We have the green. This is a manufacturer. On some medications, not all, but some medications, they will be contributing 20%, and Medicare will be picking up their 20%. In some cases, the manufacturer will not have to contribute right here, and Medicare will be picking up 40%. But even in that scenario, the plan is picking up 40% more cost for prescription drugs. Now, in the perfect world, this would be aimed at getting money out of the pharmacy benefit managers, because of course that's what Congress wants to do. They're trying to squeeze it out of the system. Well, unfortunately, they've got to pass through the carrier. The carrier has almost no control over what the pharmacy benefit managers do. So they're getting a bigger bill. Here's their 40% more. They're not getting more from Medicare. So it's like, how do we cover this cost? And then the Congress says, well, control your cost. Okay, but we're dealing with prescription drugs, right? We got to go and tell the pharmacy benefit managers to control the cost. Well, They could share in what they've been getting back as rebates. That would help. But can we expect that? No, I would not expect that whatsoever. I seriously doubt that would happen. So the pharmacy benefit managers just look at the carriers and say, "Bud, that's your problem. That's not mine. They can't touch us. Go figure it out." So what has to happen? They have to do something to control cost. They're going to have to raise premiums. You've already seen this if you're a Medicare recipient on most plans. You've seen that we've gone from flat copays to percentages. All of a sudden, over the last, since 2023, really it started in 2024, the vast majority, it hit us a little bit in 2023, you're seeing a percentage in tier 3. So if you have a medication like Eliquis or Xarelto, they say it's $600 a month. Now that might be what the pharmacy benefit managers say it is. Now that's not taken in consideration. They're probably getting 35–40% back on a rebate that they just happen to not be sharing. But guess what? We get to pay the percentage from the big price. So you're going to be paying up to 25% of $600. You're paying $150, right? But we're seeing that more and more and more. Prior authorizations, step therapies, quantity limits, we're going to see more of them. They have to control prices. The way I explain it is there's no easier money than there's no easier money to spend than somebody else's, right? So if you like shopping, it hurts if you're spending your own money. But if you're spending somebody else's money that was gracious enough to give it to you, it doesn't hurt at all. So because of that max out of pocket, carriers have to be careful. Because if somebody goes into the doctor's office and they need a particular medication, the doctor might have some choices, right? The patient might have some choices. And the doctor might turn to the patient and say, "Well, I have to start a medication for you. We have a couple of choices. There's one for $500 or there's one for $5,000. Which one would you like to use?" Well, if they know they've already hit catastrophic or how we already hit their max out of pocket, then they're going to say, most people will say, "Well, I want the $5,000 one. That must be better, right? Must be better." Well, that doesn't mean it's any better just because it's more expensive, but it's not their money. So there has to be step therapies that tell the doctor and the Medicare recipient, it's like, "Hey, we're not paying that $5,000 med from day one. You got to try the cheaper one and fail therapy. And then if that happens, we'll discuss paying the $5,000 one." But that's a lot of money, right? And we're already trying to control cost. So we're going to have more prior authorizations, more step therapies for sure, and some quantity limits. There'll be more people forced to hit that $2,000. Unfortunately, we need more people. They did the same thing, right? With the ACA marketplace, we need the healthy people to pay for the sick. And I'm not dogging this. Just trust me, I'm not dogging this program. I'm just saying that is a fact. We need healthy people to pay for the sicker people. We do. Now, we would need less of that if we could rein in the pharmacy benefit managers and make them at least share some of their rebate. But until that can happen, this is what we've got. We're also going to see formulary restrictions. People are going to have choices of different plans. We're going to see a massive disruption in the PDP plans this year. We're going to see massive disruption even in the prescription drug plans that's included in Medicare Advantage plans. Pay attention to your mail because it's coming. So, of course, industry watchers are concerned. I'm concerned about the ability for Part D to be able to weather the storm if we're not very careful. And, and this can definitely be another video one day, is talk about the Demonstration Act, because when plans went in the first week of June and submitted their bids for 2025, the standalone prescription drug plan premiums were skyrocketing. The average was going to be over $179 a month for the average prescription drug plan. CMS panicked and came out with what they're calling the demonstration program for a 3-year program, where they've jumped in and said, whoa, 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 we can't have this. This is huge disruption. People are going to get mad. We have politics to think about, because unfortunately, I think that was part of this decision. And we're going to subsidize, even though the whole goal of the plan is to save Medicare money, to keep those rates down, because I don't think they anticipated rates going that high, premiums going that high. They're now spending money to subsidize the standalone PDP plans so that it can keep those rates down. Now, is it going to keep the rates completely down? No, it is not. We're still going to see plans with some pretty high premiums, but there's a lot of stuff to realize in that I will cover maybe tomorrow, the next day. I'll post some more trainings, because there is more on that you need to be aware of. But let me get to this a conclusion. So predictions for 2025, and we're already seeing them. Higher premiums. That's the whole point of that Demonstration Act, was to circumvent these higher premiums. It can't do it totally, though. So will we see higher premiums? Yes, we will. Less plan choices. We are going to see less plan choices. I put in here potentially non-commissionable PDP plans, because agents get paid commission. We have to get paid for working. So if you have an agent and you use an agent in order to help you review your plan and make decisions on what would be best for your plan, your drugs for the year, comparing all your options, and they help you enroll into a plan, we have to be paid for that. We have to make a living too. Some plans are likely to make their PDP plans non-commissionable, which means an agent is not going to be able to help you enroll into a drug plan. That's a scary thought, because that means there's a lot of people who might not know how to navigate the system, who might not be able to look at all the details. Medicare Part D is extremely complicated. There's a lot of things that have to be looked at. It's not just the premium. It's not just the copay. It's also TROOP, that true out-of-pocket that I mentioned. There is differences between a basic alternative plan and an enhanced alternative plan. What gets counted in getting somebody to that $2,000? Those are things that need to be talked about. But if agents cannot help consumers, that's a bad thing, because as an agent, we have to carry errors and omission insurance. If we're not paid a commission for help, if we're not paid for a job of helping somebody enroll, our liability won't cover us in a lot of cases. And we can't expose ourselves and our families and our livelihoods. We want to help. God knows we want to help. Agents are very passionate. They're very loving. We have very tight relationships with our clients. And it's heartbreaking to the agent community, the fact that this is likely to happen. And we're going to be forced to either work for free and risk ourselves, or we're going to have to tell our client, unfortunately, I can't help you with your drug plan this year. That is something that should never happen. Congress needs to fix that immediately. If they can fix that before annual enrollment period, get it fixed. That I'm passionate about as a pharmacist, as an agent, and as somebody who truly adores my clients. Don't make agents abandon their clients because we're not covered because the plan decided to go non-commissionable. If that happens, fix it. Otherwise, we have a lot of Medicare recipients that are going to be disenfranchised and they're going to be steered, which is something that CMS forbids agents from steering. We don't steer. The vast majority of on-the-ground agents, I know thousands of them personally, we don't steer. We adore our clients. But call centers don't have a vested relationship with clients. Their mission is to just enroll somebody, move on, just quickly enroll them and move on. You got to deal with their drugs. It takes time. I'm a pharmacist. It takes time to put somebody's drugs in. Make sure you have them all in there. Make sure they're all on formulary. If you have plans that are non-commissionable and somebody has to go to a carrier, that carrier only has their plans to offer. And this has been my question to people in this industry before now, is if you have Mrs. Smith that is on 3 brand name meds and she needs all 3 brand name medications, and she has to go to the carrier for help to select a plan, and none of their plans have all 3 medications on the formulary, what are you going to do? What are you going to do? You don't have the option of checking with that other carrier and saying, Mrs. Smith, we don't actually offer you a plan that has all your drugs on formulary. I'm going to send you over to this other carrier so that you can get on their plan. No, their internal salespeople are going to put them on one of their plans despite the fact that all their drugs are not on that formulary. If this happens, call your congressman. We need to fix this before October 15th. That must be fixed. Stricter formularies, expect it, we're going to see it. You may have to be flexible. Talk to your doctor, talk to your pharmacist, talk to your plan. You might have to be flexible to change drugs in order to get into a drug plan. And as we talked about, more drug utilization reviews. Well, I don't know how long I've talked. I get very passionate about this. If there is one thing that I can say, and if we could make this video go viral, I would so love it, not because it endorses me. I don't care about that. I care about our Medicare recipients. I care about Medicare Part D. I care about our agents who are passionate about helping consumers select plans. It is not about how much we make. Granted, we need to make a living too. We do. We have families to support. But we do a lot of work for our clients for free because we passionately care about our clients. They are our neighbors, our friends, people we go to church with, we see in the grocery store, we run into them at their local restaurants. These are people in our communities. These are not people on an 800 number that don't care at all about a consumer. So Congress, Medicare needs to recognize who are your allies. Agents actually are compassionately trying to help Medicare recipients in a positive way. If you have any questions, please call me, Medicare as well as Congress. Call me, Norma Johnson, right? Email me, norma@yourmedicarepharmacist.com. Email me. I'm happy to answer any questions. I know this industry well, but by golly, we cannot have carriers steering plans like that and then knocking agents out of it to where we can't help to protect our clients. We got to fix that. We can do better. We're not the enemy. We are the friend. So let's get together. Let's actually do something to help protect and help our Medicare recipients get through this year. It's going to be a rough annual enrollment period. If we all work together, we will be able to get through it. And then hopefully in 2025, Congress and Medicare can smooth out some of the bumps. We are going to have bumps, I assure you. But as long as we just stick together, we will make it through. Please share this video so that we can get the word out. I need Congress and I need CMS or Medicare to fix some of these things before annual enrollment period. Again, my name's Norma Johnson. Email me at norma@yourmedicarepharmacist.com. You do not need to email me to just say I did a good job on the video. I'm kind of putting my email out there, not for consumers to actually email me, but if perhaps Congress or people who are in the decision-making process, CMS, gets their hands on my video, maybe they will reach out to me. I would love to help be part of the solution to protect our seniors and our Medicare recipients. I'm going to end the presentation there. I appreciate all of y'all's time. And let's get ready for a very active annual enrollment period. I hope this video was helpful. And I appreciate y'all. Have a great night.